Can I ask you, how many people here at the minute perform lone AF surgery apart from the faculty? Anyone else in the audience? And are any of you doing more than, let's say, 20 cases a year, more than 1 or 2 a month? So there are 2 of us. So I guess that there's about 50 cases in the UK done a year if you talk to the literature and the results. So we're very much in an evidence-free zone at the minute. So my intention is not to run through all the different procedures, all the advantages of all the different procedures, all the disadvantages, and grade them in terms of invasiveness and efficacy, because I think you will decide yourself what is the right way for you to tackle setting up a programme, and you've got far more educated people than I am around it. So what I want to do is run through some common principles that I use to develop my programme in conjunction with Guy and the rest of the electrophysiologists in the Southwest. I'll be very clear now, I don't know the right answers. I don't know the best platform by which to do this thing. All I can say to you is that you need to deliver a safe AF programme. It is confusing because there are several iterations of different technologies, but as you listen to the experts, I hope you'll get some idea of the ways to go forward. So the first thing I'd say to you is that you are just a very small cog as a surgeon in a massive EP programme. And if you go into the electrophysiology programme thinking that you're going to be able to treat all the different arrhythmia, atrial fibrillation that's referred in, you will not even get in the door, at least in the UK you won't. The patients will come to you through your electrophysiologist. So you need to sit with your electrophysiologist and ask them the sort of patients that they struggle to treat, the sort of patients that they would like your help treating, and the ways in which you can try and help them and enter into their world. They have the arrhythmia nurses, they have the referrals. So if you think on the first referral you get, I'll treat this patient, that'll be the end of it, and that's I'll follow them up and then discharge them, that'll be fine. I would warn you that you won't get much interaction and much traction with them. So you must treat them and be in synergy with them and look at how you can benefit them. And the second thing I'd say to you is whichever technology you pick, whether you pick a standalone thoracoscopic procedure from one side through to a bilateral VATS procedure, which you'll hear more about, through to even a stenotomy or minimal bypass or mini-thoracotomy and a full bypass. You need to be able to deliver it safely. You need to have good efficacy and a good understanding of the data around it. You need to get over the learning curve. There are only 2 of us in the UK that are doing more than 15 of these a year, and I suspect there are not that many in Europe doing many more. And certainly in the US, we just saw NIVAD's data, there is probably not a more prolific AF surgeon. He had 120 cases over 10 years, so he's doing 1 a month over 10 years as a highly prolific surgeon. So you need to be able, if you're going to deliver this, to get over the learning curve and be able to do it well. And you also need to understand the patient experience. So as you listen to the different methods, I would certainly go through that. And the questions that I asked myself were, from the electrophysiological perspective and the patient's perspective, is a stenotomy acceptable? I personally don't think it is, but some people are advocating doing a stenotomy and doing it that way. Is a VATS procedure acceptable, or should you go for a mini-thoracotomy? Should you do it unilaterally or bilaterally, and which way could you do it safely? There are transdiaphragmatic procedures now available, and you need to think about whether you would rather pursue that route. You need to talk to your electrophysiologist and have a discussion with yourself about whether you want to use bypass or not. There are those people who are doing a full procedure on bypass. Many of us do an off-bypass procedure. I had no VATS experience when I started, so I wasn't prepared to take on a highly complex procedure. So you need to think about where your skill set lies in that. Understand that you're going to do low volumes, and also make a decision about how you want to treat the left atrial appendage, because there are ways of treating it from the right side, but I think it's quite difficult, and if you want to treat the left atrial appendage, you're going to have to commit yourself to some sort of left-sided procedure. The other thing just to say to you, which is slightly biased to the UK surgeons, is you've got to pick something which is clinically practical. The reason I say that is you'll hear a lot about hybrid procedures today, where they're done in the same operating theatre with an electrophysiologist. If you have a hybrid theatre in your centre and you can get an electrophysiologist to come in and you can take the theatre all day to do a case, that's great. I live in a hospital where I don't have a hybrid theatre, and due to scheduling problems and winter pressures and black alerts, for me to get an operating theatre or to get a patient to come to an operating theatre and then straight to a cath lab to have a single-stage procedure would be very difficult. So we've designed our procedure around 2 stages, just from a practicality perspective, so you need to think about that. And you also need to think about how viable it is economically in the UK. If you use multiple devices, although they're on pass-through, you may start to get questions. And you can also play some little elements with the coding that will help you. So if you just want, in this world, to do a thoracoscopic radiofrequency ablation in the UK, that will track to this HRG, which in 2012 attracted this sort of fee. If you excise some fat and some ganglia and you document that in your operation note and you ablate them, as was discussed earlier, you'll attract this sort of fee if you code for it. This is very attractive to people when you're only doing a procedure which doesn't go to ITU and can be done within, can get a discharge within 48 hours. So as you listen to these stories, don't only think about the clinical pattern, think about how you can safely deliver it, what your electrophysiologist would want, and the kind of facilities you have and the coding that you'll be able to use to get there. And that's really a summary of what I'd like to think about with the different methods of the ways that you will hear about how to be able to deliver these services in the future. And from there, I think, Bart, would you like to come and start? Thank you very much.